Well, I'm going to have the privilege of introducing the topic that you're here for, as well as our moderator. But first, you get a disclaimer. And I'm not going to be able to read this one as fast as we tried to do the one this morning, but I'll do my best, okay? So, actually, I don't have to read very much because the presenters are on the green sheets on your tables. So I am to advise you that they are there. And also to remind you to please complete the pre and post tests on your tables. I'm also going to take an opportunity to tease you a little bit because continuing legal education does not require a pre and post test. So just so you know, this is really complicated and I'm proud of you. Thank you for doing your continuing legal education, and we're really proud to be able to help offer some of that to you. So a reminder to complete the evaluation form regardless if you are on the health track or not, because your feedback matters. All right, well with that, I have the privilege of introducing our moderator, Gretchen Doborvitch. Gretchen, right here, serves as the Public Health Policy Manager for the American Indian Public Health Resource Center under the Master of Public Health program for North Dakota State University. Gretchen received her Bachelor of Social Work from Minot State University and is a licensed social worker in the state of North Dakota. Previously, Gretchen was the Vice President, North Dakota, for the Minnesota-North Dakota chapter of the Alzheimer's Association. She has over 20 years of experience working in geriatrics, including caregiving, social engagement, professional and community education, care consultation, policy, admission, and marketing. She has presented at national conferences, various events for a number of organizations, including the Administration on Aging, Council of State Governments, Volunteers of America, and the American Aging Society. Gretchen currently serves on the North Dakota Rural Health Association Board of Directors, and she has also represented Fargo's District 11 as a state representative from 2016. So join me in thanking Gretchen for being here to moderate our panel today. Thank you. Have fun. We'll see you later. Good to see you.
Good afternoon, everyone. Just to start out a little bit about health and all policies. If you live in New York City's Upper East Side of Manhattan, your life expectancy is 82 years. If you live in the Bronx, it's 78. Residents in my Central Fargo neighborhood have a life expectancy of 81 years. If you live in Scranton, North Dakota, it's 78 years. And if you live anywhere in Sioux County, it's 68 years. Public health research has determined that our zip code is one of the biggest factors in our health outcomes, even more so than our genetics. External factors called the social determinants of health have a significant impact on our health and life expectancy. Social determinants of health vary by zip code and even by neighborhood, impacting residents who have little and in most cases no control over changing them. The social determinants of health include economic stability, employment levels, living near or below the poverty level, high medical bills, the physical environment, air quality, healthy housing, are there green spaces, transportation, and good roads. Education is a social determinant of health. What are the literacy levels in that zip code? Access to early childhood education, high school graduation rates, and higher education participation. Food is also a social determinant of health. If residents are living in chronic hunger and lack access to fresh, affordable, healthy foods, it dramatically impacts their health outcomes and their longevity. The community itself is a social determinant. Is there tension and high stress in the community? Are community members integrated and social support systems exist for all members in the community? And the health system itself is a social determinant of health. Are there providers that are accessible to residents? Do people have public or private insurance coverage? And what is the quality of the care that they receive? Social determinants of health cannot be improved by one individual alone. It takes entire communities and lawmakers to change policies, systems, and environments. Health in all policies is a collaborative approach where the health of all communities and citizens is considered in policymaking, leading to policies that positively impact social determinants of health. This afternoon's panel will be discussing just this, health in all policies. And it's my pleasure this afternoon to introduce Heather Austin. Heather's the Executive Director of Tobacco Free North Dakota. Heather joined the team at Tobacco Free North Dakota in October of 2016. She has over 13 years experience in the nonprofit industry, with 5 years at the Bismarck-Mandan Chamber of Commerce and another 5 years working for other statewide organizations prior to Tobacco Free North Dakota. Heather has built relationships and coalitions all across North Dakota. Working with people and bringing groups together is her favorite aspect of her work. Our second panelist this afternoon is Jody Fetch. Jody is a registered nurse. Jody has been a public health nurse at Custer Health in Mandan for the past 21 years and has been the director of nursing for the last 8. Custer Health established the first syringe exchange program in North Dakota called Mandan Good Neighbor Project. Our third and final panelist is Mr. Paul Gunderson. He is the Economic Development Director at the Job Development Authority in Harvey. He has also led the Dakota Precision Ag Center in Devils Lake. Paul has a PhD in Education Administration and a master's degree in computer science. He serves on the advisory committees for schools of public health at the University of Iowa, Colorado State University, the University of Nebraska Omaha School of Medicine, and the Marshfield Clinic Children's Ag Center. Please join me in welcoming this afternoon's panelists.
Thank you so much for that introduction. I'm so excited to be here and appreciate the opportunity to visit with everyone today. I'm going to have to give an additional disclaimer to the one that you've already heard, in that my PowerPoint presentation has many, many slides that I will not get to cover. We have a very tight time frame today, but I wanted you to have information for after the fact. And so even though I won't speak on very many of the slides in this presentation today, it is something that will be made available for you to take afterwards and hopefully learn a few more tidbits from it as you go. Just a little bit about Tobacco Free North Dakota. We are a statewide independent nonprofit agency. We have a board of directors that helps us with our governance. They are located all across the state, and I am, like was said, the executive director, and we are currently working on hiring some staff, and so that's pretty exciting for us to grow our organization. Our mission is to improve and protect the public health of all North Dakotans by reducing the serious health and economic consequences of tobacco use, and that is our state's #1 cause of preventable disease and death. A few statistics just to give you a little background on why we promote tobacco prevention and control policies. 1,000 adults in North Dakota pass away each year from tobacco-attributed diseases. And you can see by the graph located on the side there that by far surpasses many other causes of death combined every year. 300 kids under 18 are going to become new daily addicted smokers, and 14,000 kids now under 18 are going to die early because of smoking, and that's more than the entire population of Bismarck Public Schools, to give you an idea of scale. This costs our state a lot in terms of money and lost productivity. Every year, $326 million are spent by taxpayers in North Dakota, and the reason we hope that our policies can get put in place is not only to save lives, but to save money too. So some current rates, these were updated just very recently. Whoops, too fast. And some of them are quite shocking. Our adult smoking rate has leveled off over the years and hangs out between 18 and 19%, which is about a fifth of our population. The smoking rate has dropped dramatically, which is very exciting since the late 1990s, when it was in the mid-30s. In terms of a percentage rate, it's gotten all the way down to single digits, which is phenomenal. But it's a little deceiving. Our high school student e-cigarette use rate is skyrocketing, and new numbers just came out 2 weeks ago. 33.1% of our North Dakota high school students are admitting to vaping now and using e-cigarettes or juuling, and you have to kind of cover all the terminology because they don't equate it as being the same thing. Comparing nationally, you can see North Dakota trends up in some instances. And so it's, again, something that we really hope that we can promote in our state for policy. Here's where I'm going to start going fast now. And so you can see what we're up against in terms of nicotine products and tobacco being available, exponentially more so than even McDonald's and Starbucks across our nation. And the amount of money spent advertising that product is astounding. I'm going to review or kind of skip over some of what is in the products, but I want to show a picture of all the different types of products again, because I don't think we always connect what everything entails. And so it's not just cigarettes we're talking about when we talk about tobacco prevention and control policy. It's a variety of all different types of products that can be inhaled, ingested, used orally, used in your lungs, and with the vaping, I'm going to get into that just a little bit extra. Nicotine delivery systems, electronic nicotine delivery systems, are a catch-all term that we use to talk about all the different vaping products available. So when you hear someone talking about using e-cigarettes, vaping, juuling, all of that is essentially an electronic device that heats up liquid content to be aerosolized and put into the lungs. And in many cases, they almost always have nicotine. Some of the comments that you hear back are that they can buy non-nicotine versions. Juul accounts for about 70% of the market, and there is not a no-nicotine version of Juul out there. And so nicotine is the addictive substance that keeps people coming back for more and make it so hard to quit. Okay. Here again is where I'm so sorry that I'm going to skip all this great information for you, but I want to get to the piece about policy. So tobacco prevention and control policies, there are a variety of them that we promote and speak about across the state and that you hear about across the country, and some of them have been in the news more than others. Tobacco 21, you've probably seen a lot of national headlines highlighting that one, simply because we're up to 11 states now that have enacted the age of purchase to 21 instead of 18 or 19. And so that policy is meant to try and get products out of the high school age group. When you're 18 and can legally buy a product, you are very likely to have friends who are still 15, 16, 17, and in many cases, you're still going to high school with them. And so it keeps those products accessible in the school systems. When you're 21, you're likely off to college or working in your career, and you're just not as prone to being around those high school age or those underage youth. Increasing the price of tobacco products is something that here at Tobacco Free North Dakota we've worked extensively on in the last several years. It's a CDC proven best practice for reducing youth initiation and promoting cessation to current users. By increasing the price of tobacco by $1 or more, dramatic increases in health outcomes are shown as evidence-based outcomes for that policy. And so we talk in terms of raising the tax on cigarettes. In our case in North Dakota, part of the work we've done in the vaping area is to try and get those products classified as tobacco because they currently are not in North Dakota. And so to get them looped in to being affected by the current policies we already have in place is a big part of what we're working on, and then getting them to have parity with the other tobacco products in that they're licensed and also taxed as what they are, which is tobacco. We talk about tobacco-free parks in schools, point of sale. We have a wonderful statewide indoor smoke-free air law that's actually one of the best in the nation, and that is a policy that we have checked off the list, but it's always under discussion as to whether exemptions can be made for that or it can be rolled back. And so it's something that we work to preserve and protect because we know that the vast majority of North Dakotans love having smoke-free air in buildings and places of work, and we don't want that to go away. And then funding for our comprehensive tobacco prevention and control program. And this is all part of a three-legged stool that I'm talking about right now. And that is a way that you can continue to have effective health being promoted across North Dakota through the funding of that program, so that prevention policies are being discussed in local communities, through local public health units, through other partners in a variety of ways. And so as you can see with our CDC best practice three-legged stool, we have just one out of the three, we need to have higher tobacco taxes. North Dakota ranks 48th in the nation right now for our tobacco taxes. And then our comprehensive program, while it is well funded and we are in the top 5 in the nation, it's not funded to the level that the CDC would actually recommend. And so we do always promote having more money spent on the health and wellness policies that we are talking about here today. ND quits, excuse me, I'm going to back up one second. Also to mention it, for our tobacco comprehensive program funding, we do partner with the Department of Health quite often, and they house our ND Quits platform, which is actually one of the best cessation quit lines in our nation also. So North Dakota does have quite a few things we get to brag about, which is great. Informing decision makers is part of what we do with our education and advocacy, and we talk a lot with local entities, with local constituencies. We do grassroots advocacy building and outreach, and then we are active at the state capitol during legislative session and the interim, and so you can see some of the work that we've done in the past and that we continue to promote. We also try to have a media presence across the state to get our messages out there, and hope that public support and public outcry in some instances, with the vaping epidemic being for instance, can help us sway legislative or decision maker opinion and actually have some policies get put in place. Social media becomes more and more key. Youth advocates are another area that we have really expanded out into. We just hosted 2 statewide youth summits this past fall, one in Bismarck and one in Fargo. And between the two, we had just over 200 North Dakota youth come together to talk tobacco prevention and control policy. And if anything's going to give us hope for the future, I think it's our North Dakota youth. They are amazing and astute, and I'm so proud that they're becoming very well-educated advocates out there. I know that we do questions at the end, and I think I've stayed within my allotted time. Oh, I get a thumbs up. But again, I know there were a lot of slides I was not able to cover. If you have questions even after we're all wrapped up and done here, I can hang out in the audience for a few minutes and talk to individuals. But I thank you for your time today, and I look forward to hearing our next 2 panelists.
Good afternoon. I am just waiting for slides to come up. There we go. I'm going to be talking today about the harm reduction program, which is called Man and Good Neighbor Project. We are a syringe service program. Why did we start a syringe exchange program? I had a nurse that bugged me and bugged me and bugged me and bugged me. And so in 2015, we had an MPH student that came and found that we truly had a need for syringe exchange. Our hepatitis C rate in Morton County had more than doubled since 2013. And we had 46 cases of hepatitis C reported in Morton County in 2017. So we know that from the CDC that users of syringe service programs are 5 times more likely to enter substance abuse treatment. They reduce overdose deaths and save healthcare dollars. When you look at somebody with HIV, we're looking at about a $400,000 medical bill. With hepatitis C, it's right around that $70,000. So we reduce needle sticks among the public and first responders also with our syringe service program. So in 2017, we testified in front of the legislature, thinking that we were going to have a lot of opposition. I have grown to have big shoulders throughout this whole process, but there wasn't any opposition. It was great. We moved forward, and then we had to talk to our Board of Health. Our Board of Health is made up of 5 of our counties. And I didn't know how that was going to go, but the day I came to the Board of Health, the director said, "What are we doing about the opioid crisis?" So it was just wonderful. It moved right in. And then we started applying for funding. I met with our chief of police. He said he would cooperate with the law, wasn't really for syringe exchange, but would cooperate. And then we started our application process with the Department of Health. We conducted meetings with our staff because some of our staff were kind of on the edge. They didn't know if this was going to be a good thing, that we're going to have people that use IV drugs coming into our office. We also had a neighborhood meeting and nobody showed up, which our administrator said, well, that's a good thing, nobody is having a problem with it. And then we had a community meeting that we had about 100 people that participated either with us at the health unit or with Facebook Live. After we had our plan, we met with the Department of Health Disease Control staff. Then we trained our staff, went on to order supplies, and started serving clients on January 16th of 2018. Right now, I have 4 nurses that are trained. We had 1 exam room dedicated to this program. Now we have 2. We keep growing, and you'll see as I go through these slides, statistics keep growing. We offer hours on Tuesdays, Wednesdays, and Thursday afternoons from 1 to 4. Tuesdays and Thursdays, I have 2 nurses that actually serve clients. And our office location, we used to be in the courthouse, and people would have to come through a metal detection. We would not have been able to offer syringe exchange, but we have moved to a strip mall, so we do not have metal detection. Safety is a big concern for everybody with syringe exchange, and I have to say that, we have been very fortunate. We have only had 1 person that's gotten a little nasty, and all I did is walk around the corner, and she settled right down. Lessons learned. There's always lessons learned with new programs, and our growth was greater than funding for supplies. We are able to get, staffing paid through different funding, but supplies for syringe exchange are really difficult to get funded. We continue to have persons that are not in favor of the program, so we're always trying to educate. We do a lot of referrals, and they are extensive, so we are looking at getting a social work student to come and help us with some of those referrals. And data is really important, and I have to preach that because sometimes our nurses think, we just have so much data that we're collecting, and it is really important for those funders. When I did this PowerPoint, we had 235 clients. We now have 250. 129 of those were hepatitis C positive. We are at 139 being positive, and we still have 1 HIV positive client. So with harm reduction education, our nurses are conducting education at each visit. They work on disease prevention, how to inject properly. We have working people that don't want tracks showing, so they are injecting in their breasts, between their toes, in their legs. We see it all. And, so our nurses are teaching them that, it's not safe to inject in your breast. You're going to end up with cellulitis, and it's not a good practice. We also talk about safe disposal, and we have added a kiosk for the community to bring their syringes in. Our syringe exchange clients do have to bring in their syringes to get clean syringes. They have to bring us dirty. And, we encourage referrals to proper resources. So what we provide to our clients on a weekly basis, they can have 20 syringes max. We give them alcohol swabs, hand sanitizer, cookers, filters, sterile water. A lot of times they're cooking with whatever they can find, which can be Coca-Cola, it can be chocolate milk, it can be whatever they come across to do their cooking. We also offer antibiotic ointment, of course, condoms, naloxone, and biohazard buckets. When we first started this program, methamphetamine was the drug of choice. We are seeing opioids coming in stronger and stronger, which is unfortunate. We also provide referrals for medical care, mental health, substance abuse treatment, and we do have a grant right now that we are able to house Face It Together, which is a peer-to-peer counseling every Tuesday, and we have licensed addiction counselors from Heartview every Thursday. So that has been wonderful. So people, if they are ready, they can go to see a counselor right away. And when I did these slides, we only were having Face It Together twice a month, so the new statewide opiate response grant has added another day to Face It Together. So it's exciting. Mercer County has asked us to start a program in Mercer County in the Beulah Coal Country Community Health Center. We are starting that process right now. I am meeting with them on the 19th of November, their staff and their neighborhood, and then we'll go on with the public hearing after that. We did conduct a focus group in Sioux County on the Standing Rock Reservation in Fort Yates. They are not ready. They think that we need to do a lot more education. They know that there's a problem, but they're not ready for syringe exchange yet. And there is some issue with the law. The tribal law is different than state law. So we do have to look at that very closely before we move forward. So I guess we'll take questions at the end. And I'm going to pass it on to Paul.
Thank you. And again, welcome to our session this afternoon. As I wait for the slides to come up, permit me to indicate that my colleague in arms is right over here on this side. Joy is our Director of Public Health for Wells County and has been invaluable in terms of our collaborative activities together for some time. I'm wondering, pardon? No slides? Oh my. All right, let me work from my output. You have the handout in front of you, and I'll run through the assignment that I was given, which was to provide a summary of the process we deployed when engaging in an effort that addressed non-communicable disease within our local population. Non-communicable diseases are typically the most commonly found diseases amongst many rural populations, including central North Dakota. These include diabetes, some forms of cancer, of course, heart disease, and obesity, although there's some empirical evidence that obesity is in part the result of contagion from social activity and other support systems. As we noted at the outset of our presentation, these diseases are commonly associated with risk factors that include the choices that local communities make when engaging in economic activity. They include occupational pursuits, again, choices individuals make, or the limitation of choices occupationally in local communities. They include physical exercise levels, where to live, personal dietary intake levels, types, and of course the use of addictive products, which is a good bit of what we're focused on this afternoon. Let me now turn to our process, which we deployed across time in Wells County. It's a county that houses the city of Harvey, serving approximately 13,600 to 14,000, almost 15,000 people across the 5-county area. One of the unique features about Harvey is we're about 60 to 100 miles from everywhere in terms of provision of medical care and other forms of educational and economic activity. We began the process by collecting some basic scientific data and information about the prevalence of these kinds of conditions within our population. Then we went through the process of identifying target areas and the interventions we wish to deploy. We went through the process also of briefing our local Board of Health. That was absolutely essential. I happen to chair that Board of Health in our county, so that perhaps eased that process a bit. I briefed our city boards as well. Harvey is one of those communities which possesses 18 volunteer boards and other forms of governance. The statement we make locally is everyone believes they have a voice in what goes on locally. A huge hunk of that, of course, is exercised in the local tables of knowledge. We have at least 6 of those in the restaurants across our community, but some of it occurs in a more formal manner. We had to go after program support. And in order to initiate the program, which is largely focused at this point on physical activity, there's some other facets to it as well. We sought funding, of course, within, from our city, from the Wells County District Health Department. We applied and received funding from the St. Joseph's Foundation in Minot. We applied for funding from 2 of our local philanthropic organizations. Those dollars flowed. We also applied for funding from the North Dakota Department of Transportation in terms of creation of walkways. We are presently conducting a program activity we began this past spring in our elementary schools in Harvey, and then also my job development board. For them, I might add, this was a relatively new experience to focus on the protection of health status as a viable economic development activity. And so the paper you have in front of you is an attempt to underscore some of the empirical evidence associated with conduct of this kind of activity. And I would add that I've tried very hard to identify useful resources in terms of footnoting in the paper. I'm not done with that yet. That's why it's stamped draft. But it seems to us as we went through that it was really crucial to underscore this program with empirical data. I have a couple members of my JDE board that are just adamant that whatever we do within the community has to be empirically driven on the economic development side, partly because we've had some experience at the civic level with adventures that did not have adequate empirical evidence, and quite predictably they failed. So we're not willing to go through that process again. I would add, in terms of the data sources that you're using, there's an awful lot of stuff that's been printed in some journals, which I would encourage us to take a very, very careful look at. For 21 years, I was director of the Division of Statistics and Epidemiology in the State Health Department of Minnesota. And one of the takeaway lessons I had from that entire experience was document, 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 but they'd better be reputable. And so you'll see in the paper that I'm drawing from resources published in The Lancet, the premier European journal, Science, the premier US journal, of course some of our other clinical journals, as well as we documented what was necessary. Now, when designing your program, let me underscore two things. First of all, I would really encourage you to use logic models. CDC is adamant about that in terms of many of the initiatives that we're involved in. You heard that I'm on the advisory panels or scientific advisory panels for a number of centers around the nation, mostly high mountain areas and here in the Midwest. Virtually all of those initiatives required documentation with a fairly lengthy, detailed logic model. I would encourage you to use that. Make sure that you're maintaining your context and contact with your local leadership as you go through all of this, because our experience suggests logic models aren't universally known nor appreciated in many of our communities. It's kind of a new adventure, and it takes some getting used to, but they can be very, very important as you structure your resources. And then I would encourage all of us to build locally. We'll use the grant dollars as a way of jump-starting what we believe is important and needs to be done. But going forward, we've got to support and buttress with local resources insofar as that is possible. That provides us then, once we move to local resources, with the opportunity to launch new adventures in other arenas, such as those that have already been mentioned this afternoon. Very, very crucial, and make a huge difference in the health status of our populations. From the perspective of local zoning, local control, the local economic development environment, it's a rich milieu within which to work. We're focused on walkability at this point in terms of prevention. That means that everything we do, and Harvey has just moved through rebuilding virtually every street and avenue and all of the infrastructure in the city, approximately $21 million in a community of 1,635 people in the last decade. That has given us the opportunity to do everything we needed to do in order to ensure that virtually everyone can walk around that community, they can move around that community, and everything is accessible. Now, we've got businesses that still aren't in compliance, and that's part of my role, is to bring them in as soon as possible. But communities, as they make these strategic investments, do have the opportunity of ensuring that handicapped accessibility is ingratiated. All of the sidewalks are at least 6 to 10 feet wide, following CDC guidelines. Inclines are kept to 5% degrees or less. All of that stuff is so crucial to ensuring that this community is ultimately livable and engaged in health activity. Thank you.
In the few minutes that we have remaining, we'd like to take questions for any of the panelists. So if you have a question, please raise your hand, and Chrissy will come around with the microphone. Well, I guess if there are no questions, thank you again to our panelists this afternoon, Heather Austin, Jody Fetch, and Paul Gunderson. Thank you for presenting on Health and All Policies this afternoon.